Chapter 6 is a discussion on vascular disease. Okay, I won't get finished with this completely, but I'll get finished with part of it. So then we'll start back up on this next week. The vascular disease problems you tend to talk about in the lung is pulmonary edema. Okay, pulmonary edema is an abnormal accumulation of fluid in the extravascular spaces and the tissues of the lung. And there's two types, basically. Type 1 is basically where it goes into the interstitium. We do know that capillary membranes are very permeable, okay, but the alveolar membrane has a very limited permeability. It's considered tight junctioned. Basically, pulmonary edema follows the simple laws of Starling's curve. So hydrostatic pressure increases can significantly cause transudation of fluids. Decreases in oncotic pressure can also cause transudation of fluids. So all of these things are possible causes of pulmonary edema. Okay. The different stages that you see in stage 1 is that the capillary leaks out into the interstitial space and then eventually causes peribronchial cuffing, which causes expiratory wheezing to be evident in this individual. So the first sign of actually pulmonary edema is not desaturation, but it's actually wheezing on expiration because of the edema that occurs around the bronchus. Okay? Most of the time, the lymphatics become widened by this increased volume in increased volume in the interstitial space, and it is able to clear out the system so you don't develop any signs of pulmonary edema. If you wait too long, though, eventually it will extravasate due to increasing interstitial pressures into the alveolar segment, and the person will then go into stage 2. Stage 2 is what we call alveolar edema. Okay, that's when the fluid actually moves across into the alveoli. This leads to a surface tension that actually increases, leading to edematous alveoli to shrink, and you develop significant development of atelectasis to develop in this individual. What you try to see is that ventilation is ineffective at that point, and what the body tries to do is it tries to shunt the blood to areas that are being better ventilated. So this person can develop significant hypoxemia. They do get severe dyspnea and orthopnea, and if it's really severe and it's very rapid in onset, you'll get frothy red sputum coming out. And red means that you've actually got hemoglobin actually getting out, or red cells actually getting into your alveoli. That is pretty significant, and that's what's called exudative at that point. Okay. So make sure you understand the difference between stage 1 and stage 2. This picture sort of explains it in one really quick fashion. I think it's really helpful to understand this. Pulmonary edema can be due to basically Starling's laws, which is excessive hydrostatic pressures. So rapid elevations in pulmonary artery pressures can lead to rapid development of pulmonary edema. You can also get epithelial damage. Okay? Epithelial damage can be caused by irritant gases or near drowning, and then the actual fluid transudates through. Or you can have endothelial damage, which is much more severe in the sense that the endothelial lining of the alveoli, and that's when you get ARDS or endotoxemia, or you also see that in patients that develop fat emboli. So endothelial damage is a much more severe form of pulmonary edema. It's more consistent with stage 2 edema. Epithelial damage, pulmonary edema tends to stay in stage 1 unless you wait too long and you don't treat it aggressively. Pathogenesis of increased capillary hydrostatic pressure is usually due to one or two causes. One is excessive back pressure from the left heart failure. Usually that occurs when the mitral valve becomes incompetent. So you have usually a left-sided myocardial infarction with a severe mitral regurgitation. Or you may also get this with prolonged mitral stenosis. Okay? You may also get it from excessive preload, where you get now increasing stroke volume into the pulmonary arteries, and you get pulmonary hypertension. It may also lead to increases in capillary hydrostatic pressure. And then you may have also situations where you have pulmonary veno-occlusive disease, which means that the outflow tract somehow is obstructed. That's pretty rare. So that's something that usually I would not be too concerned about. Again, what you see in this kind of disease process, increased hydrostatic pressure, is the fluid is pushed out into the interstitial space. As long as the lymphatics can keep up, it stays in stage 1. If the lymphatics can't keep up with excessive fluid in the interstitium, then it begins to extravasate out into the alveoli, leading to stage 2. But usually that's a later sign. The other thing that can occur is due to increased capillary permeability. That's the epithelial damage. That may develop from low permeability edema or high permeability edema. What you're looking at is epithelial damage due to inhaled substances such as chlorine gas and sulfur dioxides and nitrogen dioxides can be very, very dangerous for people. If you have kids, one of the things that I recommend in Florida is there's pools everywhere, especially if you have one in the backyard. Almost all of us that are trying to cut costs will try to do our own pool work, but it's very dangerous in the sense that you have usually big tubs of chlorine tablets. And kids are always incredibly curious and silly. And they'll open up one of these chlorine tubs, and the chlorine gas in that is very high. And we had 2 kids die about 2 years ago. They put their heads inside the chlorine, inside the bucket, and they were both dead before they could put their heads out. Okay, so chlorine gas is very, very lethal, to say the least. So if you do have that around the house, make sure that it's sealed properly and make it only the adults can open it. And that's why they're so hard to open. Endothelial cell damage causes circulating toxins as well, and the endotoxins the damage, and that's much more severe. Radiation can also cause a very significant capillary permeability to take place. High levels of oxygen for prolonged periods of time can also induce this kind of issue. And ARDS and high protein concentrations in red blood cells can lead to this problem as well. You can also see it from reduced lymphatic damage, lymphatic drainage, seen from increased central venous pressure. So patients that have chronic pulmonary hypertension or developing acute increases in pulmonary hypertension, like from ARDS, patients that are getting overtransfused or having an MI may also have reduced lymph drainage. You can also get obstruction of the lymphatics due to like lymphangitis carcinomatosa. Yes, sir. Because what ends up happening in that situation is that it starts extravasating out because of the capillary leak syndrome that happens in the lungs. It tends to basically have 50% of the protein content that's in the bloodstream. So if you get very, very high protein content, it begins to pour out and it starts acting like a sink and starts sucking fluid into the lungs. So you have to be careful with that. Usually not something you see very often, though. You can also get it from something that most people don't think of, which is decreased interstitial pressure. So when can that really happen? Well, 2 ways things that can happen. One is from rapid removal of pleural effusions or pneumothorax. So putting in a chest tube in somebody is not benign. Okay? If you have a large pneumothorax and then you re-expand the lung very, very fast, you can get flash pulmonary edema in that lung. I've seen that happen because people are too daggone vigorous. They put them on too much pressure too fast. Just go slow. Okay? It's not a rush. At this point, you've converted it into an open pneumothorax or a simple pneumothorax, so it's no longer an issue. It's just rather just put the pressure slowly up so it begins to suck the air out. Most patients are not real happy when you're not so much when you put the chest tube in. It really hurts when you're re-expanding the lung. When the pleural finally touches the chest tube, that's when people are not happy. Okay, so that's how you know the chest is actually the lungs re-expanded properly. Usually the person will scream a little bit and say, "Hey, that really hurts." Okay, and usually after that, then they get settled back down again. Usually you have to give them a little narcotics to smooth them out, but you can always tell when a lung is reinflated. If you inflate it too fast, you'll see frothy red stuff coming out of the mouth. That's bad. You gave that person flash pulmonary edema, and now you're really behind the 8 ball. Now you got to put positive pressure in somebody who has a pneumothorax. Not something you want to do. Okay. Hyperinflation can also take place. And the other very common problem for us, I've seen these at least 10 times in my career, is a thing called negative pressure pulmonary edema. Negative pressure pulmonary edema is very unique to anesthesia, okay, and to the ICU. What ends up happening is that you have, under normal circumstances, when a person occludes their larynx, usually they don't have much volume in their lungs. Okay, so they're not able to really generate a lot of negative intrapleural pressure. But if you have somebody who's young and healthy and very muscular, so the only time you see negative pressure pulmonary edema is usually in young males. Okay, the person will bite on the endotracheal tube and then basically suck down real hard with their diaphragm, and the negative pressure that's created inside the chest will reach minus 45, minus 50, and then it will literally suck the blood out into the alveoli, and the person will get flash pulmonary edema. It's really impressive. Okay, it only takes one breath to do that. Okay, so one of the things that we teach you is don't let the person bite the endotracheal tube. Okay, if they don't bite the endotracheal tube, this won't happen. Okay, it only occurs if you can bite the endotracheal tube. So in young males that are very muscular, be really aware that they tend to wake up violent, first of all, because a lot of times people go to sleep afraid. And, you know, so one of the things, the first things that people do is they try to take in big, deep breaths that are inappropriate in a situation like that, and they bite down on the tube in the process. And that's when you get this negative pressure pulmonary edema. Once you've seen one, you'll never forget it because it's so impressive. If you do get it, it's not time to extubate. It's time to put positive pressure on that individual, put them on CPAP if you want them to spontaneously breathe, give them some Lasix, and you got about 3 or 4 hours before you clear this thing out, and then you extubate them at that point. But so now you're stuck. You went from an outpatient, easy procedure, they could have gone home, and now because you forgot to put the bite block in, now it's going to become a prolonged recovery phase, and hopefully you get the patient extubated and not have to send them to the hospital. Okay? So make sure that you put in your bite blocks and protect the tube if you can. You can also get decreased colloid osmotic pressure, which is an overtransfusion. Hypoalbuminemia will also cause this. If your albumin levels get too low, it will prevent fluid from pulling itself back out of the interstitial space, and that will lead to pulmonary edema, which is a question he just asked me a few minutes ago. And then you have decreased interstitial, I just went through that, sorry, I went the wrong way. There's also uncertain etiology of certain diseases, such as high altitude. High altitude most likely has to do with the brain controlling things. We think it's related most likely to almost like a neurogenic pulmonary edema. When you go up to high altitudes, one of the first complaints that people do is when they get high altitude sickness is they develop a severe headache. Okay? And it's usually due to hypoxia. Okay? And what you do in that situation is you put the person on CPAP and keep the lungs working properly and give them additional oxygen. Okay? And get them off the mountain. Because if you don't, the chances of them going into cerebral edema and dying is pretty high. So you don't want to be there and having to transport somebody down from there at that point. But the cerebral edema is an important part of what causes most likely the pulmonary edema. Okay? Because what it does is instead of HPV working properly, it begins to dilate inappropriately. So perfusion velocity inside the pulmonary vasculature increases dramatically. Okay? So in this person now, they're getting too much hydrostatic pressure from too much flow from the increased cardiac workload that the person's doing from high altitude work. And usually those are young men, that's what you're seeing this in, or young women, when they get this high altitude sickness. Okay? The treatment of choice is put them on CPAP, which then limits perfusion through the lung to a certain degree, and it also improves oxygenation. And so neurogenic pulmonary edema is very similar to a high altitude pulmonary edema. It's almost the same. That's why I think it's related to the brain. Overinflation can also cause a very similar disease process. You can disrupt the alveolar membrane and as well as capillaries. And then heroin, not necessarily heroin is a bad drug. It is a bad drug, but I'm saying it's a bad drug in the sense of how they cut it. They will add baby powder to it. They'll add Drano. I've seen some really bad things happen to people that are injecting heroin. The one that kind of didn't work very well was the Drano. People came in with fulminant pulmonary edema. They were injecting Drano, 60% Drano powder for 40% heroin. So almost everybody died. We had to tell the dealers, hey, stop doing this. You're killing your customers. So we actually did. We actually told them it's not a good idea what you're doing, unless you don't want to have anybody sell it to you. So and they stopped and they cut it with something else. So they usually use any junk they can find to cut it. And but Drano's not a good idea. I don't know what the hell thought of that idea. So must not have much medical training. Clinical features include dyspnea. Breathing is shallow and rapid, because what you're seeing in this individual is, if you look at their compliance curve, they're down here now. So in pulmonary edema, you're breathing fast, and shallow. So that's all the tidal volume you can accept. The treatment of choice usually in these kind of situations is give them PEEP or CPAP. And what it does is it drives the FRC up to a normal point, and then the tidal volume increases dramatically. And the way you know it's working is as you give the person CPAP, all of a sudden the respiratory rate from go to 32 down to 21. And that's when you see that the person's tidal volume all of a sudden increases dramatically. All you've done is just shoved them up the FRC curve and made them breathe much, much better. They get much worse when you just lay them down. So most people don't like laying down with this kind of problem because when you lay somebody down, FRC falls further, so it shoves them down the curve more. Not a good place to be. So most people with this kind of problem are not going to let you lay them down in the first place. Okay? They're not going to be real happy with you. If you're going to tell them that you're going to have to intubate them, I would pre-oxygenate them sitting up first, and then tell them at the last second, well, I got to lay you down and get the breathing tube in, but we're going to do it at the last second, and try to do it at the last possible second. And sometimes I'll even wait for the person to be asleep before I try to lay them down. It's that dramatic in the sense of the person gets severe shortness of breath. Mechanic-wise, you see that the diaphragm is workloaded. It's very, very high. It's from the reduced distensibility of the lung, and it moves the pressure volume curve to the right, causing a reduction in FRC. You see the increase in airway resistance can also be because the bronchioles get the compression, so you'll see here wheezing on expiration. And the static compliance, which is the delta B, which is a change in volume over delta change in pressure, is significantly reduced. Okay, so the static compliance, which is this equation, change in volume over change in pressure. Static compliance we can do in the operating room very easily because delta V is your tidal volume and your pressure is your peak inspiratory pressure minus your PEEP. That's your delta P. Okay, if you don't have any PEEP, then it's peak inspiratory pressure. Okay? And then you can tell how much. So if somebody's becoming, if somebody's having increasing pulmonary edema, what happens to peak inspiratory pressures? This is going down, and this is going up. Okay? So if you see increasing peak inspiratory pressures, you got to think in your back of your mind, do I have pulmonary edema going on in this case or not? So, okay. Well, here's where I'll stop, and that way give you a little extra time for lunch, okay? And we'll see you guys later.